Simple block, we won't take much time on this. I think we have only these are the penultimate block. We have one axillary block with PNS and one axillary block with ultrasound. I promise that I won't take a longer time, hopefully. So now everything is set and we are going to do the axillary block. Axillary block is very important for everybody to know because it's very helpful in critically ill patients who come for small upper limb procedures, especially when you don't want to produce any involvement of the phrenic nerve in patients with COPD coming with a distal radius fracture. And so similarly in patients who have comorbid illness where you do not want to take the risk of producing a phrenic nerve injury, phrenic nerve blockade with your local anesthetic solution, you need to know axillary block. And the other reason to know an axillary block is, suppose if you are given any form of supraclavicular approach and when you see that some nerves have not been blocked, it's a good way to do a rescue block. So in that way it's very good. So I'm going to demonstrate an axillary approach block the way I do it. So if you see, I have switched on, we are using a HNS 12. I'll set the current of 2 milliamps, 0.1 millisecond pulse width, and we have the frequency at 1 hertz. And now, the way I do it is, I do not go high up into the axilla as it is described. So I go on to the flat surface. After the axillary crease, I go into the flat surface. I use my thumb to palpate the axillary artery. So what I have done now is, what you see as a mark is the axillary artery, and the tip of my thumb is at the lowermost part of the axillary artery. So I apply a lot of pressure so that I fix the vessel, and I also make a movement of my thumb so that I take the artery with me above so that I won't puncture the vessel. So the point of entry of my Stimoplex insulated 50 millimeters needle is I go just below the artery, flush to the surface. So I used the SNSC technology with this one. Can you see the triceps contraction?
Yeah, there are strong contractions.
Yeah, this is at 0.4 milliamps we have decreased. So we are getting an excellent radius response. We will aspirate and inject. And with 1 cc, the twitches are disappearing.
You entered with 0.4 as a setting, is it?
No, 1 minute, yeah.
You entered the area with 0.4 as a...
No, we started with 2 milliamps.
2, okay.
Yeah, and then slowly brought down to 0.4 milliamps.
Okay.
At 0.4 milliamps, you saw the triceps contractions. At this point, we started injecting the drug. The radial nerve is at the epicenter between the ulnar nerve and the median nerve. So when you want to give an axillary approach, if you get a triceps contraction at 0.4, maybe to 0.3 maximum, if you inject about 30 ml of the drug, 25 to 30 ml of the drug, it would spread and block the ulnar nerve as well as the median nerve, because it's at the epicenter and we'll get a very good block. So we are aspirating for every 3 ml, we are aspirating and injecting the drug. And after this, as we all know, the only nerve that is not blocked by this is the musculocutaneous nerve, which is outside the sheath. So after completing the administration of the local anesthetic solution below the vessel, I will demonstrate to you the block of musculocutaneous above the vessel. Musculocutaneous in the axillary is slightly more tricky with the PNS than the ulnar and the radial and the median nerve, because you give 30 ml? Yeah. Give it? Yeah. Because the course of the musculocutaneous nerve is quite different from individual to individual. So now, can all of you, those who have appreciated that what I have done is, you don't see a bulge after injecting 25 ml, which shows that the whole drug is inside the sheath.
Okay.
And we just went below the vessel. Now I would demonstrate going above the vessel. The median and the musculocutaneous is above the axillary artery. So first what I did, I went flush to the surface below the vessel. Now I will again palpate the axillary artery. So now what I'm trying to do is, I'm palpating the axillary artery and trying to analyze the uppermost part of the vessel. So now I'm going to go flushed to, take that one. This is to block the musculocutaneous. Is it visible? Can you see the picture, Dr. Bande?
Hello. Yes.
Dr. Bande, can you see
Yes.
this?
Yes, we can. Can you hear me?
Yeah, now I can hear you.
Okay.
So I've put my. Can you come up? Can you? No, here from here. Yeah.
Yeah. We can see that. Yeah. Okay.
Yeah.
But
So what I've done is I'm palpating the axillary vessel, trying to define its upper margin. So flushed to the upper margin, you have not pierced, but can you see the response of the median? You can see the flexion of the udatik. Ask him to show the contraction.
yeah, show the distal part. Yeah.
Yeah.
Yeah, we can see that. Yeah.
So that's the you see the flexion, and this is the median now.
Median.
Yeah. So why you see the multiple contraction is because with the HNS12 we are using the SNSE technology, the latest form of stimulating the nerve with 3 continuous impulses. Okay, so this is at 0.4, this is the median now. I'm not going to inject any drug, raise it to 2. I'm not going to inject any drug, but no, keep it at 2. Yeah. Now what I'm going to do is, I'm going to trying to get the musculocutaneous. So I am going to push the needle, tip of the needle, slightly superior and cephalad. Can you see the biceps?
Yeah, we can see the twitch in the bicep. Yes. No,
Can you see the biceps contraction?
Fine. What exactly you just turned it cephalad?
Yeah.
And what
First
was the depth added?
yeah, it was less than a millimeter. Yeah.
Less than a millimeter.
Yeah. Like it was just from what I see, I moved just 0.25 centimeter inside. Yeah, that's all. No, we lost the biceps. 1 minute. Yeah. Okay. Decrease it. Decrease it. Decrease it. Okay. 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 So I will actually what you see is median now.
Yeah. So.
Yeah. Actually, we got the biceps and we lost the biceps. We keep it at 0.6. Now I'll try to just. Once you get the median, you need to push the tip of your needle slightly superior and cephalad to the median, and then look for a biceps contraction. Yes.
Correct.
Can you?
So what was about 5 millimeters or what was it?
Yeah, less than 0.5.
Okay.
Can you see the biceps
Yeah,
now?
we can see that.
Yeah. So this is at a. Yeah. So this is at 0.4. Yeah.
So you're going to inject here.
Flexion at the elbow. This is for the musculocutaneous nerve.
Okay.
Yeah. Aspirate, inject.
Bala, this is Swaroop.
Yes.
If this patient is going to require a tourniquet, can you just show everybody how you infiltrate for intercostobrachial?
Yeah, sure. Yes.
Thank you.
Yes. Just to recapitulate, below the artery is the ulnar and the radial. Ulnar is the most superficial, followed by radial. Radial is in the epicenter of the sheath. If you block with getting a radial response, with the tip of the needle close to the radial nerve and inject about 25 to 30 ml, it will block the median, the radial and the ulnar nerve. The only nerve that is not done is not blocked is the musculocutaneous. So for blocking musculocutaneous, you go above the artery. First, flush to the arterial surface when you inject the needle perpendicular to the artery and parallel to the ground. You first get median. So when you get a median, what I did was, I didn't inject any drug because we have already placed the drug inside the sheath. The tip of the needle moved slightly superior and cephalad in relationship to the median, less than 0.25 to 0.3 centimeter in this patient, and you had a biceps contraction which was shown with an elbow flexion, and injected the drug. So now we have done all the 4 nerves here are blocked. And as Swaroop had pertinently asked, that when you give an axillary block, it's pertinent that if you're going to put a high tourniquet, we need to block the intercostobrachial nerve, which is T2, and which is not a component of the brachial plexus. So if you need to block that, we need to use a hypodermic. This is a subcutaneous infiltration, and we need to block the intercostobrachial. Can you show the marker?
Just, can you change the camera direction? Yeah. This needle was 5 centimeter long?
this was a 5 centimeter long needle,
Okay.
and initially we got radial at about less than 1.5 centimeter.
Okay.
Median similarly we got at about 1 centimeter, and at 1.5 centimeter we got the musculocutaneous. But having said this, I also want to tell you that I had applied a firm pressure on the vessel and fixed the artery. So when you do this, you compress the tissues there. So in fact, the
When
depth.
you had relieved that, we could see it was 2.5 centimeter in.
Pardon me?
When you relieved your pressure by
No,
the
that's,
left
yeah, when I released my
Then we
pressure,
could see that
then the
it-
skin, yeah, that's right. The skin just welled up, and then it looked at a depth. But I always fix it nicely and firmly, so that number one, I get over the vessel so that I don't make a puncture, and second thing is fix the artery very well. So now, as Swaroop asked, it's important that when you're doing the whole procedure under axillary block, and you wanted to block the T2, the supply of T2 distribution is
camera
like,
can go either on your left or right, whatever.
yeah.
Yeah, okay.
So this is the shoulder. So the T2 starts from here. If you keep the axillary crease like, so this is an area that is supplied by the intercostobrachial. So now we are not going to bother about this zone because the tunica is not going to be applied there, but we are going to get bothered about this zone, that is a cutaneous distribution. Try to use as small needle as possible, preferably 26 needle. This is what? 26, no. So actually, this cutaneous distribution we need to inject with the local anesthetic solution, and that's it. It's okay. So it's predominantly a cutaneous infiltration that you need to do. One of the other option is based upon the surgical site. You can even go for a slightly lower level of tourniquet. So if you do that, if it's a forearm procedure and a wrist procedure, if you go further down at the level of the middle third and the lower third, then we'll be totally avoiding the intercostobrachial nerve, and then we needn't infiltrate.
Okay, that's fine.
So I think, was it okay?
Yeah, fantastic. I mean, Bala, there can't be any better thing than this.
Yeah.
We have some
Thanks,
more.
Bala. That's nice. Very nice.
Yeah, thank you very much.
Some
And
more
now
cases?
the last block is an ultrasound guided
Swaroop, you were saying
axillary.
Oh, I just
Okay.
said thanks. Thank you.
Yeah, excellent, Bala, as usual. And are you shifting to the next case now?
Yeah, that's the last case, and that's an ultrasound guided axillary block, and
Fine.
we complete the day with that.
Wonderful.
Yeah.
Bala, thank you to the whole team and all the experts who were absolutely fantastic in their job as expected. And see you tomorrow in the morning on the same ground.
Thank you very much, sir, and we learned from you. Thank you so
Okay.
much.
Thanks everybody. On behalf of all the audience, I thank the OT staff of the Navle Hospital.